see is that schizophrenia is a very devastating brain disorder. It affects thinking, language, emotions, social behavior, inability to perceive reality accurately. A lot of times what you can see is that the schizophrenics on that mental health unit, you can tell those folks. They're often the people that are talking to themselves or talking to others that are not there. They may, in fact, hear auditory or visual hallucinations. Basically, they're the people that you can tell in a general population of folks that, you know, their behavior is a little extreme, sometimes to the point of bizarre. Okay? So what we see with schizophrenia is that, unfortunately, it targets young people in their teens and early 20s. Typically what you will see is that late teens to early 20s. Though there have been some children as young as age 7 that have been diagnosed with schizophrenia. If you're interested, there is a video that I saw. It's a child locked within her mind. Basically, she hears voices and numbers, and what happens is that because her life is so regimented and bizarre, that her parents basically have rented 2 apartments. So that one parent stays with her, one parent stays with the other child, because they are not able to have the 2 children together because of her particular behaviors. And he says basically even though they've moved into 2 smaller apartments, that it basically is costing him an extra $500 a month what it was for when they had their house. So it's getting very expensive for him. One of the things that you will see with schizophrenia is that it is a spectrum disorder, meaning that it is a group of symptoms, okay? And often what you will see is that a psychosis or psychotic state will exist. Remember, psychosis is not a diagnosis, but it's a symptom. Schizophrenia is the diagnosis. That psychosis, as definition, is a total inability to recognize reality. And often these people have delusions and hallucinations. And with those, what is a delusion? Well, the way I remember it is this. A delusion is a false fixed belief. I am Cleopatra. I am Jesus. I am Homer Smith. Okay? So what you see are those are delusions. Hallucinations are sensory impressions without external stimuli. They can be auditory, they can be visual, they often can be other sensory, touch or smell. Illusions are real stimuli that are misinterpreted. For example, this guy is waving, and this guy feels that he has a knife and is going to stab him. Okay, it's a misinterpretation. So hallucinations, illusions, and delusions are what you see often with your patients that are experiencing psychosis. Now, with psychosis, schizophrenia is the most common illustration of that psychotic behavior. Basically, abnormalities, affective disruptions. And what do I mean by affective disruptions? What is an affect? feelings or emotions, okay? Those of you that have cared for patients that have undergone, are in a psychotic state, what were their moods or affects like?
Flat.
Flat sometimes. Very labile, okay? Often inappropriately labile. In fact, we have a gentleman that basically walks and will talk and then giggle because I guess the voice is telling jokes. But inappropriate emotions at inappropriate times. They have impaired social competency. These people often don't know how to interact with other people in their social group. So typically what you will see is that a large number of these patients are socially isolated and socially withdrawn. Now, these are just some example of some of the delusions that you may hear about when you're looking in the chart. Delusions of grandeur. Within 1 month, I'm going to be a billionaire, and I'm going to have a house that's right next to Bill Gates, and Alan Greenspan's going to call on me for financial advice. Delusions of persecution. My neighbors are talking about me. I know that they're going to kidnap me and hold me for ransom. Control. Someone has control. They control, the TV is controlling my mind by beaming radar into my head. Religious delusions. I think we see a lot of those. I've had 3 patients that have been Jesus, and I'm not really sure which one I want to talk to. Sin and guilt. I can't do anything right. I always mess things up. It's all my fault. Somatic delusions. They may have some kind of symptom or pain. A hammer is hitting my head. I've got daggers stabbing me in the back. All right, whereas a lot of people are using that as a simile to illustrate what it would be like. These people actually feel that there is a knife in their back. Ideas of reference. The headline of the New York Times told me that I've been assigned to stop crime. Thought broadcasting, I don't have to tell you that. You already know because you can read my mind. And often I've seen patients do this to try to, and of course during your test, I'm sure you're doing that. Doesn't work. As much as I've tried, it does not work. Thought insertion. You think this is me talking, but it's someone else. Okay, so those are some examples of the delusions that you might see when a physician or practitioner is talking about those delusions. Now, what you see are positive symptoms and negative symptoms. And we're going to talk more about those in depth. Think of the positive symptoms as excessive or additional behaviors that's not normally seen in healthy adults. Think of those as the state of agitation. Negative symptoms, that's loss of normal function normally seen in mentally healthy adults. Think of those as like depression. Positive symptoms is more like mania. Negative symptoms is more like depression. Now, some of the other things that you will see in your patients that have schizophrenia are substance abuse disorders. More than 50% have problems with drugs and alcohol. I know it's out of order. I rearranged them. I'll post this one up. But just, this slide is in there, I promise you. But just listen, okay? The other thing that you see is that not only do they have substance abuse disorders, but approximately 75 to 80% of these patients are addicted to tobacco. They smoke. Why do you think that patients with schizophrenia have problems with drug or alcohol abuse? They're trying to dampen those symptoms. They're trying to dampen those voices that they hear. Especially if they are native ones. Okay? I've got a couple of videos. One I'm going to show you, and the other one is of Anderson Cooper that actually went through a schizophrenia simulation. And he was trying to do math, and he was trying to do normal everyday things, and he couldn't do anything. But it's very, very disabling to hear those hallucinations. A large number of these patients are depressed. Approximately 10% commit suicide. 50 to 60% attempt. Okay? And one of the things that we've seen, I know at LifeWorks, is they've tried multiple times, 12 to 15, over a 10 to 15 year period. The other thing that you may see is polydipsia. And what do I mean by polydipsia? Okay? They will have a thirst that is followed by a compulsive drinking of water. They will drink anywhere from 4 to 10 liters of water a day. So, as a nurse, what am I concerned about with that? Fluid overload. If I have a patient that has a physical health problem of congestive failure, but lab-wise, what am I more concerned about?
Yeah, like it.
What electrolyte is that going to drop if I add
Sodium.
Right, sodium. And we saw that with one of our patients a couple weeks ago. Her serum sodium was anywhere from 125 to 127 because of that compulsive drinking of water. Well, what do? Put them on a fluid restriction, right? Typically. How well do you think that worked? Not very well at all. Took the cups away. I've seen patients drink out of the shower. I've had patients cut the shower off, they drink out of the toilet. It is a compulsive drinking of water. The other thing that will contribute to that low sodium is a lot of the antipsychotic medications will also lower your sodium levels too. So that is one of the things that I would make sure that you look at. If you have someone in that psychotic state, they have schizophrenia, look at their labs and make sure that they're maintaining their sodium levels. Typically what you're going to try to do is that fluid restriction, but it may or may not work because of that compulsion. Sometimes you just add salt to their food and it'll help. Or you may have to switch their meds around because that med may be contributing to it. Why am I concerned of a sodium of 125? Seizures. Okay? Now, I told you that the majority of your patients are presenting with your schizophrenia about 18 to 22 or so, okay, or younger. Late onset schizophrenia, when you're talking about, this is not late to me, but by the book it is, 45, okay? Basically what you will see is that people that exhibit a late onset of schizophrenia are at higher risk for Alzheimer's disease. So that is one of the things that you're going to need to be very, very aware of. All right, let's talk a little bit about some biological factors and some pathophysiology. Listen to my voice. Put your pen down. Okay? Genetic factors, it's not one gene. It may be multiple genes. And in fact, the latest studies, 8 to 9 genes are probably responsible. But what you've got to be careful about is that even though it may have a genetic component, one of the things that you will see later on is that even identical twins, one may be schizophrenic, one may not be, because there are environmental factors that also contribute to that. What you see is that often there is a problem with dopamine, serotonin, and glutamate. And it's not that one's up, one's down, and one's sideways. It's an imbalance, typically, of all three of those. Okay? So one of the ways that we treat this is try to maintain that balance of those neurotransmitters in the brain. What happens with someone with schizophrenia is this. What we see is that we have a filter. And it filters out that incoming stimuli. And so what happens is there's just no overload. But with your patients with schizophrenia or psychosis, they have a lot of holes in that filter. So more stimuli gets in, okay? And so they develop that sensory overload. What you see is that they are not able to block like we are. Some things you can just tune out. Now, other things that you will see is that it can be caused by pregnancy and birth complications. Typically, you will see a schizophrenia from a viral infection in utero. You may see it from poor nutrition, starvation, or exposure to toxins. And it can be, a contributing factor can be anoxia during birth process. Now, psychologic stressors, both developmental and family, and environmental stressors are not causes, but typically what these are triggers that may cause that patient to have their first psychotic break. I can think of 4 patients that we have cared for in the last year that experienced their first psychotic break in their early 20s because of stress of moving away from home, being out of parental influence, attending college, and exposure to drugs. Okay? So they may have had that genetic predisposition, but it may have been either what that psychological stress or an environmental stress that triggered that response. Okay? The other thing that you will see is that whenever you look at PET scans, and that's what these are, what you often find is that with your patients that are schizophrenic, these are some of the anomalies that you'll see in brain structure. And they're not sure which comes first, the chicken or the egg. Are these the result of the schizophrenia, or are these the contributing factors to the schizophrenia? One of the things that is seen is that you can see, this is a PET scan which shows blood flow and glucose uptake. You can see here in the frontal lobe, there's a lot of uptake, but look, it's much, much decreased in that schizophrenic patient. So what does the frontal lobe control? It's an inhibitory for emotion, behavior, short-term memory. So all of those things, if they have decreased blood flow, decreased glucose uptake, they're going to have problems with that inhibition or those emotions. Okay? About 1% of your population is schizophrenic. Typically what you will see is that early diagnosis and treatment may help to reduce some of the chronicity and help to improve the prognosis. So what you want is an early diagnosis, or just saying, well, my child is weird, or it's all teenage angst. Those are not very helpful. Definitely an early diagnosis will help to make sure that they have a much better prognosis. Now, with etiology, your patients with schizophrenia have a 20% shorter life expectancy. The majority of that is, of course, due to suicide, homicide, and 1/3 of the premature deaths would include accidents as well. Whether that accident may be stepping in front of a train or falling off a bridge, that may be in fact a suicidal attempt or just an accident, who knows. Typically what you will see is that a lot of these patients have comorbid diseases. 2/3 of them die from coronary heart disease, hypertension, emphysema, and complications of type 2 diabetes. And some of those disease processes are really exacerbated with some of the antipsychotic medications that these patients have to take to control. This is just an illustration. 1% in the general population is what I told you the incidence of schizophrenia is. But look, whenever you look at some of the twin studies, 50% of your monozygotic twins develop schizophrenia. If you have one parent with schizophrenia, 13% chance. If you have two parents with schizophrenia, 45% chance. A lifetime risk. If you look at these statistics, you'll see that it is not just genetic factors. There's also some environmental things that go along with that. All right, before we start with this, let me just show you a couple of these videos, and then we'll call it a day. There have been some children diagnosed as early as 6 or 7. What you see is that pre-psychotic phase. Basically, they sort of truck along. They may be, behavior may be a little strange, okay, compared to the rest of the population, but they have no symptoms that would diagnose them as schizophrenic. Basically, that prodromal phrase, basically you see some social withdrawal, depressive mood, and basically you will see sometimes magical thinking, peculiar behavior, and that usually appears about 1 month to 1 year before their first psychotic break. Okay, so it's sort of leading up to that first psychotic break, which is in that acute phase. So what you typically see in that acute phase is that these people do lose their touch with reality. You will see both positive symptoms and negative symptoms of schizophrenia, and we'll talk about what those are in just a minute. Third phase is basically maintenance. Switch those around because the book has them one way and the slides have them another. Phase 2 is maintenance and phase 3 is stabilization. So basically with stabilization, what you see is that those people are sort of in remission as long as they take their meds. Okay? And that is one of the things that you have to remember with schizophrenia is that it is a lifetime of medications. All right, so one of the things that you will see is that I know on a couple of the charts I've seen not just plain schizophrenia as a diagnosis. I've seen things like schizoaffective disorder and other types of diagnoses. The difference between schizophrenia and schizoaffective disorder, basically it's a mixture of schizophrenia as well as a mood disorder. So there may be significant amount of depression or bipolar disorder along with that schizophrenia. Okay, a brief psychotic disorder, basically they have one of the following symptoms: delusions, hallucinations, disorganized speech or thoughts. And the episode lasts at least 1 day but less than 1 month. Okay? Schizophreniform disorder, basically the symptoms are the same but they last at least 1 month but less than 6 months. A third of the people that have that schizophreniform disorder return to their pre-morbid functioning, meaning that they are as normal as they were before this episode, however that might be. However, 2/3 of the people that experience a schizophreniform disorder progress to either schizophrenia or schizoaffective disorder. So about 1/3 get better. 2/3, however, the disease is progressive. Now, a shared psychotic disorder, that's whenever two people, you're in a relationship with another person who's delusional, and you come to share those delusions. It commonly occurs with two people, but it can be more than one person. Okay, and one of the things that you can think about are the cults that are out there. The Tom Jones and the people that drank all the Kool-Aid and they died because they thought that the aliens were coming to pick them up. Okay? Schizophrenia, basically these are some of the symptoms that you see. You see a loss of ego boundaries. You see a lack of trust. You see withdrawn or peculiar behavior, personality changes. Sometimes they appear almost autistic. Typically what you will see with these clients is that they will have auditory hallucinations and delusions. Remember, some of those auditory hallucinations are command hallucinations. And what do I mean by command hallucinations? Don't do that. You need to kill so-and-so. You need to hurt yourself. Those types of things. They're giving that person a command to do a particular behavior. The other thing you see a lot is religiosity. Okay? How many of you have met Jesus on your unit? In fact, we've got 3 Jesuses right now. Competing Jesuses. So, it's one of those things that you see that a lot of people sort of pick on or snap to, because that is one of the delusions that they get with this particular form of the schizophrenia, and it will probably depend on their background. A lot of times what you find is that people that do have religious delusions may have had a childhood in the church, or sometimes the exact opposite. They have had no contact and they've developed their own church, so to speak. What you will see with DSM-5 Okay? Remember, that's the new Bible for schizophrenia. These are the types that they have in here. Paranoid type. And I think we've probably all seen patients with paranoia. Basically, they have delusions of persecution. They may have delusions of grandeur. And they usually have auditory hallucinations that are related to a single theme. Okay? Typically, these patients are tense, very guarded, and suspicious. What types of patients, paranoid behaviors have you seen with some of your patients on the units?
Mine said I could read his mind,
Yeah,
and so we don't want to talk about it.
thought
Because I
control,
knew it all.
you knew it all. What other types of things?
My lady was in there because she thought the people across the street were talking about it, she could hear it, but also the fact they had access to what she was thinking as well.
Right.
And so she would sit and look off in space and quite often reply to whatever she was hearing.
Right, okay. And a lot of times how like Holly's patient, how frequently do these patients with these paranoia open up to you? How comfortable do they have to be with you as the nurse for them to be able to talk with you so that you are not mind controlling? So those are things you need to think about. With the paranoia, there is a joke that says just because you're paranoid doesn't mean they're not out to get you. A lot of these patients do feel that that is the case. Now, disorganized type schizophrenia, typically what you will see is with these patients, contact with reality is extremely poor. You will see some facial grimaces and very bizarre mannerisms, and that is not due to that tardive dyskinesia that a lot of these patients develop because of the antipsychotics. What you often see is incoherent communication. A lot of mumbling, so that you can't understand what they're saying. So that basically it's very, very difficult to communicate with these folks. Not only because their communication is incoherent, but their touch with reality is so skewed. Now, catatonic. Basically what you will see with catatonia is that these people almost are stuporous or comatose. They don't respond to their environment. And in fact, they have something sometimes with these patients that's called waxy flexibility. And whenever you're talking about waxy flexibility, it's basically if you move their arm to a position, they will leave that arm in that position until you move it back down. So you put their hand up, they'll keep it like that until you bring it down. Okay? That's what waxy flexibility is. Typically what you will find is that there are two types of catatonia. That's either the stupor or coma, but there's also an excitement type of catatonic behavior. That's extreme psychomotor agitation. Movements are very frenzied, purposeless, and very destructive and violent. These are the people that destroy a room. Now, undifferentiated schizophrenia, they're usually psychotic with delusions, hallucinations, incoherence, and bizarre behavior. Basically, undifferentiated means that they don't fit into one of these other categories. And then residual is they've had a previous episode of schizophrenia, but there are no current evidence of psychosis or social isolation. These may be your types of patients that have been in that brief psychotic disorder category. Now, when you talk about schizophrenia, you're going to talk about positive symptoms and negative symptoms. The way you remember the difference between the two is this. Look at these things right here. Hallucinations, delusions, disorganized speech, bizarre behavior. Typically, when we think of positive, what do we think of? It's a good thing, right? Okay? But are these good things? Why do they term these positive behaviors then? Because they're above the normal. They show an agitation, okay? The same thing with the negative symptoms. Look at these. Blunted affect, alogia, or poverty of thought, loss of motivation or avolition, meaning they don't move that much, guys. Inability to experience pleasure or joy, aphrenidia, aphrodonia. Thank you. So basically, whereas positives are hyper symptoms, what are these? The negative symptoms. They're the depressive symptoms. And that's the way you remember between positive symptoms of schizophrenia, negative symptoms of schizophrenia. Now, some of the other cognitive symptoms you'll see are inattention, easily distracted, impaired memory, poor problem solving, poor decision making, impaired judgment. Why do you think that some of these problems occur with these patients?
Their hallucinations.
They're hallucinations, they're voices. Remember the video that I showed you with Anderson Cooper going through that simulation? Fairly highly intelligent person, but he got none of the math questions right or the test right. And he couldn't do the simple origami or making the boat. A lot of that is due to those positive symptoms that they have, those hallucinations and delusions. Okay? Some of it also may be due to some of the medications they're on to treat these symptoms. Okay? Now, affective symptoms. Dysphoria, suicidality, and hopelessness. Big thing to consider, okay? Remember I told you 10 to 15% of these people complete suicide. At least 50% of these people attempted at least once. I've seen patients on the unit just this past semester with 12 to 15 attempts. Again, our positive symptoms. What do I mean by aloof and stilted interactions? What behavior is that? What does aloof mean?
They kind of stay back from others. They don't-
Anyone have a cat? Cats are very aloof. They're sort of standoffish. They sort of look to see what's happening in the room before they decide if they're going to do anything. Stilted means sort of jerky, not smooth. Okay, so that if they do have interactions with other people, it's not the normal form of communication that you see. It's the patient is more sort of a run and gun type communication. I need no medication. And walk away. So those of you that will see these symptoms, think of those as some of your positive symptoms of schizophrenia. Now, some of the other things that I've included here are some just definitions and examples of affect, all right? It may not be in your slides, but just, the things that you just will see is, just let me go over it. If it's not in there, that's not a big deal. The difference between appropriate and inappropriate behaviors. Appropriate. One cries when learning about the death of his father. Inappropriate would be when it's told it's time to turn off the TV and go to bed, he begins to laugh. Stable behavior, smiling and laughing at appropriate social interchanges, or labile behavior, and I'm sure you've heard that term used. During a friendly checkers game, Sean, who has been laughing, suddenly knocks the board off the table and begins to laugh and wants to continue the game. Labile means jumping from one thing to another. Wanted. When Tom learns of his full tuition scholarship, he responds with only a small smile. You guys get a full tuition scholarship, I'd have to scrape you off the ceiling. Flat. Affect. Okay? When Juanita's mother tells her that her favorite dog has died, Juanita simply says, "Oh," and then goes on with no indication of emotional response. Okay? So those are some of the descriptors of affect that you'll see whenever you're looking at your chart. Now, a couple of other things you need to remember. The negative symptoms. How are these going to interact? How do these basically help or impair interactions with other people with the negative symptoms? Decreased activity and limited speech. What would that do? They're not going to be able to interact with people and form social relationships. And one of the things I think that you've probably all seen is that whenever you look at your Erickson stages of development, a lot of your patients that have schizophrenia are in that mistrust stage, or basically looking at developing relationships, social isolation, and it's because of a disease process. Okay, they're not able to move on beyond what you would see with that early adulthood. Typically what you find is social withdrawal, isolation, very poor rapport, inadequate social and occupational skills. A lot of times what you will find is that people that have schizophrenia are highly intelligent. Highly intelligent. But they're unable to hold a job because of their inadequate or poor social skills. And sometimes basically the inattention, the scattered thinking will affect their occupational skills as well. So a lot of times what we see is that a lot of these patients have to have disability in order to survive in the world. A lot of your homeless population has schizophrenia. It's one of the most significantly diagnosed mental illnesses in the homeless. Let's go back to comorbid. Canatotic manifestations. We talked about a little bit. What is echolalia?
Repeat things.
They repeat things back to you. You know, those little horrible parrot things that you bought your kids as a Christmas gift one time. and you thought, if I ever am able to take the batteries out of that thing, because it repeats everything back to you, you will see sometimes that behavior in these patients. They may repeat the same words or phrases. They'll get stuck on something. Exapraxia is basically, okay, when I cross my arms, they cross their arms. When I cross my legs, they cross their legs. So they mimic your movements. And remember, alogia is minimal speech. Now, when you're talking about interpersonal relationships, those primary positive and negative social characteristics basically impact their interpersonal relationships. Families that are able to deal with this first psychotic break, because, oh my God, what's happening to my kid? After they've dealt with it for quite a while, when this child now is in their 30s, are often not able to deal with it as well. One of the things we as nurses need to make sure is that those families have support. Basically, what you'll find is that families that are not in family therapy and have the patient has that family support, typically what you find is that the relapse rate for your patients with schizophrenia is 3 times higher than those that are in family therapy, because they need the support of the family to help them remember to take their meds or to follow through with their appointments. Age specifics, like I told you, most of the things that you will see is in adolescence, triggered by stressor, and it may be a very important loss, the death of a parent, child, or very, very good friend. Just, if it's not on there, don't worry about it. Just remember, adolescent and older adults, what you find is that most older adults have had the disorder since youth, but have not been recognized. They were just that strange uncle that you had. Okay? Remember, late diagnosis of schizophrenia greatly increases the risk for Alzheimer's disease. Now, one of the things we want to do is to make sure that these patients take their antipsychotics. And one of the things that you'll remember that Ms. Rummel talked about are a lot of the side effects or the adverse effects. Is this not in there either?
Yeah.
Okay, very good. Remember, you need to know these adverse effects of conventional antipsychotic medications. The one that's the biggie that you see with a lot of your first generations is that tardive dyskinesia. That is bizarre face, tongue movements, lip smacking, those types of movements. And you may see that with the arms and the body as well. Typically what you'll find is that with some of these medications, those are permanent, okay? They don't go away whenever you discontinue the medication. Some medications, they do go away. But long term, if they've been on these antipsychotics long term, the chance of that tardive dyskinesia disappearing is very rare. Now, basically what we're going to do is antipsychotic medications treat those hallucinations, those delusions. And often what you'll find is that the majority of your antipsychotics are going to treat those positive symptoms of schizophrenia. You'll add some drugs to treat the negative symptoms as well. The drugs work only as often as these patients take them. And how many patients have we seen come in because they've been off their meds for 3 months, 6 months, a year, or whatever? Okay, so continuing to take the medication. Remember, these meds are not a cure. They are a treatment of the symptoms.
My patient said that his meds were what were making him crazy. So with the paranoia,
Yeah.
what are you supposed to do?
Well, and one of the things that you will see is that a lot of times, and we saw it with one of our patients just recently, he developed what we feel is in MS, the neuromyelitic malignant syndrome. He did not have the fever, but he had all of the other symptoms. Well, unfortunately, what happened is we transferred him to med, and one of the medical doctors said that that was, the medicine is what caused your problem. Okay, so now what we're having to do with this poor guy is do forced meds because he thinks that we're poisoning him with the antipsychotic medications. Because the other doctor told him that this medication was the reason for your problem. So extreme paranoia with taking meds, and unfortunately it's sort of a 6 security guard, 3 nurse type deal to get this guy to take his medicine, which is unfortunate because how do you think that that contributes to his paranoia? Makes it much, much worse because, you know, right now what this guy is perceiving is that 6 security guards, 3 nurses, and jabbing them with this needle is that what we're trying to do is hurt him.
This is probably a stupid question, but for patients like that who can't go without their meds because it's going to make it worse, but will take their meds, I mean, are they just hospitalized the rest of their life? I mean, what do you do?
Basically what they're hoping with this gentleman is that, number one, he's IVC'd for admission. Okay, there is an IVC court order for forced meds. Okay, and what we are hoping is that once his medication level gets to where it's able that he's not having so many hallucinations and delusions, that he will voluntarily take his medications. But what you find with a large number of this population is that you will have an IVC order for outpatient meds. Meaning that if they do not show up to Daymark or they don't show up to wherever it is that they've got the order for their medication, then basically the police come and pick them up and force them to come in to take their medications. And if they are unable to find them or they continue to refuse to take their meds, then they probably will be IVC'd for inpatient treatment. Now, a lot of times what you will find is that patients that are extremely resistant to taking medications, unfortunately, a lot of those patients do end up in Broughton for long-term care, where you will find that they will be continually forced to take their medications. So there won't be, again, harm to themselves or others in the place. But that's one of the things that you'll see. We are hoping with this poor gentleman that he, once he gets a sufficient level, will voluntarily take meds. But We'll just have to see. Now, what you will see is that, remember your conventional antipsychotics that are non-phenothiazine, they are going to have similar side effects but less sedation. Your atypicals treat both positive and negative characteristics. Now, one of the meds that you're going to need to know about that you will might see either on NCLEX or sometime soon is a med called Clozaril. Clozaril. It's an atypical antipsychotic, but it's sort of one of those drugs that's a last-ditch effort, okay? It's a very broad spectrum antipsychotic. It controls both positive and negative symptoms without producing extrapyramidal symptoms. Well, why don't we put everybody on this? Well, the reason is that it is a medication that can cause agranulocytosis to the point that if your physician puts you on Clozaril, you have to go on a national registry and they have to report blood results, white blood cell count, complete blood count every month. So it is one of those meds that because the agranulocytosis can be fatal, these people have to be followed very carefully. So if they're not compliant with taking their meds, how compliant do you think they're going to be with coming in for monthly blood draws? Okay. It is a med, again, if you're on it in the hospital, you have to, again, make sure that they have an informed consent for it. Getting an informed consent on someone that has been IVC'd is probably not one of the things that you can do very well. So remember, Clozaril is one of those meds that you have to watch white blood cell counts for, agranulocytosis. Now, one of the other antipsychotics that you'll see used quite a bit with schizophrenia is Risperidone or Risperidone. A couple of things you need to remember about that, other than what Ms. Rummel talked to you about, is that it can increase prolactin levels. And that can lead to menstrual disorders, decreased libido, and osteoporosis in women. With men, high prolactin levels can cause lack of libido or sexual dysfunction and impotence. So how compliant do you think that's going to be?
Not to keep bringing up my patients, but he was on Risperidone, and it actually caused him to
Develop gynecomastia?
absolutely, and so that affected his self-esteem level because he was on it as an adolescent, which helped lead to his paranoia and psychosis. It seems like a lot of this stuff just is a cycle.
Right, it really is. It gets to be very vicious. And that's one of the things that you need to remember is that a lot of your atypical antipsychotics not only can cause gynecomastia in men, the other thing that they do, guys, that you need to remember is that it can alter glucose metabolism. You ever hear in a report, their glucose level was this, their A1C was that, okay? But they're not diabetic? Why are you doing A1Cs on someone that's not diabetic? because what you will find is that these atypical antipsychotics can predispose these people to type 2 diabetes because it alters glucose metabolism. That's why you will find that they will do A1Cs on everybody that pretty much comes into LifeWorks. I'm sure they probably do something similar at the VA. Side effects of your antipsychotics. Again, they can increase social isolation because that constant uncontrollable movement is very irritating. They may be embarrassed to be in public. You may see those strange, writhing, bizarre behaviors cause that patient to stay in their room because they don't want anyone watching them. What I would tell you to do, guys, is look at this video. It's an excellent video on tardive dyskinesia, and it uses that Ames scale. And you may have heard them talk about Ames, because what it does is it's an abnormal involuntary movement scale, and it will rate the severity of those movements. Higher score means higher severity. Okay, so if you hear someone talk about Ames scale, it's talking about movement disorder. Tardive dyskinesia, 46% of the clients who take first-generation meds for more than 2 years develop them. And as I said, they can be permanent. You know what's scary thing? What do we typically give in the hospital for nausea? Phenergan or Zofran. They can cause them too. Okay. Phenergan is a phenothiazine. Zofran is ondansetron. One of the things that they found is that higher levels of Zofran, this tardive dyskinesia can be permanent. Okay. Neuroleptic malignant syndrome, or NMS. I know Ms. Walker talked to you about in relation to anesthesia and the OR. But this can also happen in your patients taking those first-generation antipsychotics. Basically, it's high. The risk is higher if they're taking 2 or more, or they have an organic brain disease of some sort. Mortality rate is 14 to 30%. Basically, what we would do is transfer this patient to the ICU, discontinue the meds. Tylenol, cooling blankets, IV hydration. But one of the key things is to maintain the airway to the point that these patients may have to be intubated to protect their airway. Basically, bromocriptine or Parladel and dantrolene basically is to decrease muscle rigidity. What you typically see is those white blood cell counts extremely elevated CPK, and myoglobinuria. This gentleman that we thought, you know, Ms. Walker talked about that high elevation of temperature. This guy had a normal temp, or at least as normal as we could assess, because we weren't getting an oral, and sure as everything, weren't getting a rectal. Okay, this is the same guy that we got 6 people holding down to take his meds. Well, what he had were that extreme muscle rigidity. High white count was 20,000. His CPK was 10,000. Okay, so if I've got someone with CPK of 10,000 and I've got myoglobinuria, what am I really worried about as a nurse? Kidney failure. This guy was extreme risk for acute kidney failure. Okay, it's sort of the same type of thing that you see with the rhabdomyolysis, with that breakdown of muscle tissue. Okay, what the kidneys try to do is to clear that debris from this muscle rigidity, and they're unable to do that. And they get clogged up, and you may see acute renal failure. This guy was also dehydrated because he wasn't eating or drinking, which basically contributed to these problems, because not only did he have that high CPK, but he didn't have the volume to try to flush his kidneys out. Okay. Cardiac side effects that can cause prolonged QT syndrome. Some of the symptoms that you'll see. Okay. Basically what we worry about with prolonged QT, and we'll talk to you more about some EKG stuff this spring, but with prolonged QT, typically what can happen is that the longer that interval is, the more likely that heart is to start another beat. And what happens in that case is that you get this ventricular fibrillation. Basically what you're seeing is a cardiac rhythm that looks like this with no cardiac output. So death can occur. Other symptoms that you will see with some of these psychotics are cogwheeling. Very similar to what you see with your patients with Parkinson's disease. Basically, whenever they cogwheel, it's like movement with a ratchet. Okay? They are stiff, typically with muscle cramps. The presence of cogwheeling and those cramps can indicate early symptoms of extrapyramidal symptoms. Typically what you will see is they will give them cogentin. Remember, that's a med that we gave for our Parkinson's patients to help with movement. They can also give Benadryl. Basically, whenever you have a patient on any antipsychotic, that should be part of your assessment. Making sure that whenever they move, that it's a fluid motion and not that cogwheeling. Okay? Because what you're looking for are those early symptoms of EPS. All right, there's your list. Same drugs Miss Rummel went over. Again, typically what you're going to find, your atypical antipsychotics will cause weight gain. 20 pounds is not unusual. Not only does that weight gain contribute to the increased risk of type 2 diabetes, but that altered glucose metabolism is as well. So it's one of the assessments that you need to keep on top of. And that 20 pounds is 1 year. And there may be more on top of that. Some of the other things that you will see with a couple of these medications. Zyprexa is a med that they often give IM for acute psychotic episodes. It's one that can cause agranulocytosis and neuroleptic malignant syndrome, but that's rare. But unfortunately, that's what this gentleman was on that developed it. Risperdal, Seroquel, Geodon are the ones that you're going to see most often. As I stated before, Clozaril is one of those last-ditch I don't have anything else to try type meds because of the extreme problems that you can get with that clause group. Now, Abilify is a med that you will see them add sometimes. It's a new class called dopamine system stabilizers. It was approved in, I think, about 2002. It treats both positive and negative symptoms with fewer side effects. Typically, Abilify is not a primary medication. It is an adjunctive medication. So they will be on a primary med as well as the Abilify. Typically Seroquel and Abilify. Okay, because what you will see is that that Abilify will help to boost the effects. It enables Abilify. Abilify is the primary drug to become more effective. What you have to worry about is that Abilify has its own side effects like nausea, headache, vomiting, fever, constipation, and it can cause some anxiety in some people. Now, when you're talking about treatment, which is better, typicals or atypicals? Their ability to afford the medication. A lot of your atypical antipsychotic medications are much more expensive. Very few are on that $4 list. If they've had a history of side effects on one medications, they typically try another. If they have the side effects on the typicals, then they move to the atypicals. Now, some are available in declinate or long-acting forms, Haldol and Resparil. Basically, what you will see is that's 1 IM injection every 2 to 3 weeks. It helps with compliance. If I am a patient that forgets to take my medicine on a daily basis, I can come into the clinic and take one of these shots every 2 weeks or every 3 weeks. And I'm much more compliant with my meds. Typically what you will find, your patients that are IVC'd on outpatient meds will receive one of these longer acting, because it's a whole lot easier to get them into the clinic every 2 to 3 weeks than it is on a daily basis. Okay? Some are very rapid acting in IM form, Haldol, Geodon, Abilify. Sometimes they're useful for emergency treatment, but let me caution you, Haldol is one that I will not recommend for use in the elderly, because typically what you find is with the little old folks, when you give them Haldol injections, it makes them worse. It is on the VIERS list to avoid use in the elderly. Now, rapid tranquilization, usually I am Haldol or I am Ativan. Typically what I'm starting to see more now is the Zyprexa and the Geodon, because they're less sedating. Typically you can use that Zyprexa and the Geodon, I would think probably every couple of hours or so, to try to help these patients get their behaviors under control. You may hear Haldol referred to as vitamin H. Again, be careful about using it in your elderly populations. because it can have opposite effects. Bomb them, you may hear it referred to as a B52. Basically, that's not a B vitamin. Basically, it's a combination of Haldol and Ativan, and they call it a B52, well, because that's what the bomber is, but look, 5-2, okay? So that's what you will see. Some of your adjunctive medicines, Cogentin, Simetril, Benadryl, Ardane, Parladil, Inderal, and Dantrium, okay? Remember, Cogentin, Simetril, Ardane are medications that we also may give for your patients with Parkinson's disease. It helps to lessen some of those EPS symptoms. Be careful if you have patients with a history of urinary retention, because what these often do is further that urinary retention, and you're going to have a person with a bladder that's gotten extremely large. So, as a nurse, what am I going to assess if I have a patient that is on one of these medications? I know. How often are they voiding? What's the volume? This gentleman that we were caring for a couple of weeks ago, cathed him and got 800. The next time we cathed him, we got 1100. He had no urge to void whatsoever. Side effects, blurred vision, dizziness, orthostatic hypotension, drowsiness. What are these patients going to be at risk for? Falls. Okay. They often, may have some of that tardive dyskinesia that keeps them off of balance. You give them orthostatic hypotension on top of that, and that is going to set them up greatly for falls. It's very similar to your anticholinergic side effects, yes. Typically what you'll find is that for your patients with the schizophreniform that have a mood disorder along with their schizophrenia, you will see your lithium or other mood stabilizers, and it helps to reduce some of the aggressive behavior that you will see. Benzodiazepines are not used that often, but they may be helpful on a very short-term basis. Clonazepam as well will decrease some of your anxiety, agitation, and some of the psychosis. But again, your benzos are not usually used on a long-term basis on these clients because of the addictive problems that you have. All right. Let's take a break. We will finish up schizophrenia. A couple of things you're going to want to remember is that we want to make sure that we provide effective psychosocial treatment for these clients. Sometimes it's very highly structured, and that often is better for patients that don't enjoy changes in routine. Those of us that were on LifeWorks, whenever they changed out the furniture, probably saw that, because what we had were patients that were extremely agitated sometimes, and others were just so withdrawn that they stayed in their room, and it was just because of the change in the environment, because of people moving in and out, changing the furniture and the drill noises and the hammering and the whole 9 yards. So structured typically is better tolerated than a spontaneous environment because these people know what to expect. Teaching and social support is very, very important. What we want is a team that delivers services when the client needs them, where the client needs them. Remember that a lot of these patients are not institutionalized, that they are sometimes very productive members of our society if they take their medications. When they don't take their medications is when they get into trouble. So what we often hope to see are those comprehensive integrated community services. We've seen people being followed by the ACT team to make sure that medications and treatments are taken care of. We see them referred to community resources like Daymark. And Daymark is pretty ubiquitous. I mean, there's some in Concord, there's some in Salisbury, there's some in Charlotte. Those clinics are everywhere, so that we can make sure that the patients are followed somewhere near their home or their place of residence. Now, ECT can be used in conjunction with medications, but I'm not going to talk about ECT because Ms. Rumley is tomorrow after your test. Transcranial magnetic stimulation is one of the things that I have seen used. It's fairly new treatment. Basically it's like an electrical stimulator that stimulates the brain. It helps to increase the effects of the negative symptoms. It sort of takes those away. It dampens the positive symptoms. I have not seen long-term evidence-based research to say that it works one way or the other. So we'll hopefully see some more things in the future. Other things that have been tried are omega-3 fatty acids, aromatherapy, and acupuncture. Again, not much evidence-based practice out there, except that with acupuncture, what they found is that they did a 6-month study in Texas, of all places. And basically they showed that with the use of acupuncture, it showed a decrease in the duration of hospital stays. It lessened the amount of time that it took for these patients to become regulated on their meds. So that's maybe something that we see in the future. A couple of other things we need to do is assessments. Basically what we want to do is interviews with family members to see how they're interacting, as well as our physical and psychosocial assessments. Physical assessments, one of the things we want to do is the patient's ability to identify smells, because that will give you a little bit of an idea about brain functioning. Remember, a lot of these patients have extremely disturbed sleep patterns. It's not unusual to see on the report that these patients have 2.5, 3.5, 4.5 hours of sleep at night because of the side effects of the medications. It may also be due to the disease process. Polydipsia. Remember, that is one of those side effects that you see where they have that compulsive drinking. Remembering that with that compulsive drinking of 4 to 10 liters, you've got to watch serum sodium level and make sure that this person does not become hyponatremic. Some of the nursing diagnoses that you'll see, big 2. Risk for self-directed violence and risk for other directed violence. Remember, safety is going to be a key with these patients. You may also see that disturbed sensory perception, auditory, and visual. Those are your hallucinations, the voices that they hear, the images that they see. impaired verbal communication, impaired social communication, chronic low self-esteem. It may be part of it, may be due to the disease process. It may also be due to some of those side effects of the medications that you're talking about, like what Holly was talking about, the gynecomastia with her gland. Anxiety related to environmental stimuli. That may be due, again, to the hallucinations and delusions that these patients experience, the voices. Kill! All right, those types of things. What you find is a lot of times these voices are different. Some have as many as 7 to 10 different voices. A lot of times what you will hear is if they have the command hallucinations, the voices are distinct and you can make out what they're saying. But a lot of times what I've had patients to describe them as whispering. And that you can't make out what they're trying to say. One of the things that you will see are definitely caregiver role strain and impaired home maintenance for a lot of these patients. Self-care deficit, bathing and hygiene. Remember, we've seen a lot of these folks come in that definitely needed a good shower. And it's probably because that is not high on their priority list. Because hygiene may be one of the things that they forego because they feel that they're not safe exposing themselves and taking their clothes off the bed. What we hope is that we want to either reduce or eliminate symptoms. Total elimination is probably not a realistic goal, but reduction of symptoms so that they're have a better quality of life probably is one of the goals that we want to achieve. What we want to see is that they are able to communicate clearly, they increase their attention span, interacting well with others. And that may be with the healthcare team, it may be with others on the unit. We most certainly hope that it's members of their family. Okay? This is a KBOD. Prevention of violence towards self or others. Remember, I told you 50% of these patients attempt suicide at least once. So we are going to be doing evaluation for risk for suicide. We also want to do a risk for injury assessment. Because if they think that this place or this mole on their arm is a bugging device, you don't want them to gouge it out. Okay. Nicotine addiction. Remember, I told you probably 80 to 90% of your patients with schizophrenia are nicotine addicted. So that will need to be treated in the hospital, probably by either the gum, and whoever came up with the idea that you could get 2 pieces of gum every hour as the medication nurse, I'm sure is not the most favorite person in the world, but either the nicotine gum or the patches. Remember, one of the things that you need to think about with that nicotine gum, okay, it is a short-term treatment. It is not intended for long-term use because that gum can cause gum disease and deterioration of the teeth. I have a friend that's been using it for 17 years. I said, why don't you just smoke? She says, it probably would have been better on my teeth. Other implementation, remember, patients that have family members that are involved in their care are 3 times less likely to relapse. So family therapy. Typically what you find with this first psychotic break, parents are very frightened, very confused, very overwhelmed with what's going on with their child. One of the things that I have seen, guys, and just as an FYI, put it out there, I have seen at least 3 psychotic breaks in freshmen in college, away from home the first time, experience their first brush with illegal street drugs, either cocaine, cannabis, and or heroin. And those 3 drugs contributed to their psychotic break. Of course, whenever we did a further history, we found that there were some other psychotic episodes or history of schizophrenia in those families. That's not to say that those drugs caused that schizophrenia, but it may have contributed to the first psychotic break. One of the nurse practitioners that we work with over at LifeWorks basically tells all of her patients under the age of 21 that she does not recommend the use of marijuana because of that reason. She said that once they're older, it doesn't really matter. She, you know, if it helps calm them down, she's okay with it. But she typically tells her patients under the age of 21 to avoid that until you're a little older. Even though Ms. Rummel says it's the wonder drug and it treats everything, it can cause. All right. Some of the things that we want to talk about with family education, we want to provide information about that disorder, how they're going to manage those symptoms. What are their expectations during recovery? I mean, it is a long-term process with someone that has been diagnosed with schizophrenia. Typically, if it lasts that 6-month period, it doesn't go away. And they have it for a lifetime. We need to talk about medications. What are some of the roles or how they handle crises? If someone is having an acute break, what do you do? It's not something that you know, I guess you can watch CSI or Criminal Minds to learn how you go through this process, but it's not something that everyone has experience with to learn to petition the court for an involuntary commitment. So we need to help patients, families through that process as well. Typically what you will find is that in the ED there's someone, an advocate to help them with that. What are some of the early signs of relapse? Because it is much better to get this patient tuned into therapy early on in that relapse of their schizophrenic symptoms versus whenever it's full blown and very, very difficult to treat. So families and friends need to recognize what those symptoms are. Housing and social resources are key. Unfortunately, if this patient is not on disability, a lot of them are not able to work. A lot of them are homeless. And unfortunately, on LifeWorks, we discharge a lot of patients to the sidewalk because of that. Because of their past behavior at the shelter, either being violent and tearing up property or assaulting another patient, they're not eligible to go back to the shelter. The other thing you need to remember is in Rowan County, to go to the shelter, you have to be a Rowan County resident. If you're transient, you're not eligible to go to the homeless shelter. That's one of their rules. How do you prove it? Well, you've got an old driver's license, or you've got an old bill of some sort with a Rowan County address. but you're not eligible to go to Rowan County's homeless shelter unless you're a resident of Rowan County. Sometimes they have to go to the homeless shelter in Charlotte or Mecklenburg County or other surrounding counties. And some of them are discharged to the Walmart parking lot. But your patients that have disability, a lot of time have good housing. Patient that we've taken care of previously, he is extremely careful that he is not in the hospital the first of the month, because that's when all his bills are paid and are due, and he knows that if he doesn't pay his bills, then he's not gonna have an apartment to go home to. So what he does is that if he's not able to make those arrangements, you know, he may have one of the social workers at the hospital to make sure that his bills are paid out of his account. A lot of these patients do require guardians because they're not able to make their own decisions, even on their better days. So that's one of the things that you'll have to see. And part of that is the advocacy, making sure that legal issues and that an advocate is selected for this patient, because we don't want them just out on the street with no hope or help for the future. But unfortunately, what we're starting to see is that the system is getting overwhelmed quite a bit. So, questions about schizophrenia? Let me just sort of, when we talk about the right to refuse treatment or the least restrictive environment, you know, I told you that we are doing forced meds on this guy. One of the things that they are doing every time they have to force a medication on this patient, the security team has to fill out a report. The nursing staff has to fill out 5 different reports, okay? This is not one of those random decisions. Well, basically they have to go through this process to try to convince him to take the medication. If he then refuses, then they go to further methods. But what you will do every time is to work through that least restrictive method of giving this gentleman his meds. And then if you have to force, then you do assessments, you do vital signs, you make sure that that patient was not harmed in any way. So it's not that you can just hold anyone down and give them their medication. There is a process that you have to go through. And one of the things that you have to go through is a debriefing within 24 hours, just like you would for every code gray that's over at Rowan. So that, you know, how did you feel about this? Were you anxious? Was he anxious? Well, yeah. Was he able to understand what was going on? Probably not. Okay, so there are a series of questions and checks and balances that you have to do whenever you're forcing medications on some people. Okay? Questions? All right. This is one that you're going to have to know that's cognitive. Remember